The research we did at UCL in 2019 was based fundamentally on public opinion backed by policy research. So we found that about half the population believe that cancer is their main priority for better treatment. That's twice the proportion who said that dementia and conditions like Alzheimer's were. We also found strong support in the NHS, but about a third of the population doubt the quality of care they get from the NHS, and another third have got problems about early diagnosis. If we fast forward to 2019, what we find is a greater policy focus on early diagnosis, a commitment to increase the proportion with early stage cancer diagnosis from a half to 3/4. The challenge, of course, now following that is that we've had the COVID pandemic and we've got to pick ourselves up to get back to where we were in 2019.
Our study explored the patterns and the cause of predicted cancer-related premature mortality in Brazil up to 2030. The regions in Brazil are likely to be differently affected in terms of number of deaths by cancer sites and years of potential productive life loss and costs. Our results provide an additional perspective based on the human capital approach for local public policies for both prevention and treatment access, in order to tackle cancer premature mortality inequalities according to the needs of each region. In conclusion, specific health policies, local service planning, and social policies are required to improve this scenario.
As an economist, I fear high drug prices, which could waste money, and I fear too low prices because these could impact research and negatively affect innovation. My conclusion for this research project: clinical data and evidence are necessary for decision-making, but they're not sufficient alone to make transparent and rational decisions. By that I mean, if someone, a patient, a member of an expert panel or regulator, is facing a trade-off or looking at different outcomes, they are always using some sort of value judgment to weigh the benefits against the risks to arrive at a certain decision. I think it is very telling that even today, there's not a single HTA or value assessment framework being used that is transparently and mandatorily using patient preference information.
Our study focused on commercial insurance coverage and financing of new oncological drugs in Israel. At the background of our study was the role of health insurance. In the event of serious illness like cancer, the insured faces both the uncertainty of the disease and the cost of its treatment. At time of need, cancer patients face the uncertainty of the disease, its difficulties, and its financial direct and indirect costs, and look up to their health insurer to help finance the most appropriate treatment. So we found that even though insurance is one of the most important financial mechanisms to ensure affordable care of patients in time of severe disease, today the financial risk arising from the use of innovative cancer technology fails to meet at least 3 of the insurability criteria. We asked the question, since we do see policies that cover innovative cancer technology, how do the insurers hedge the risk? Overall, we found 18 different tools that are used by insurers in the pharmaceutical policies, not including tools set by the regulator. So our analysis raises the questions of what is the responsibility of the state in the context of innovative pharmaceutical risk coverage, and how and to what extent should the government intervene in the market. We explore 2 possible mechanisms, such as mandatory medication insurance, supplemental medication insurance layer, and so on. Nonetheless, the situation in itself will require policymakers not only to deal with the rising prices of cancer care therapies, but also with the limiting of people's private insurance alternatives.